Word cloud just kind of gives you a rough idea around the type of symptoms that can happen, how common they are. And the important thing is it's not just hot flashes and night sweats. There are a lot of symptoms that can happen around this time. Some people might get no symptoms. Some people get very significant symptoms. Some people get them for over 10 years. Symptoms can change day to day as well. I won't list them all, but just to give you a bit of an idea. In terms of physical symptoms, we've got the vasomotor symptoms, what I mean by hot flushes, night sweats. Around 80% of people who get symptoms will get some kind of vasomotor symptom. You get the sudden sensation of heat centered in the upper chest and the face. It quickly spreads out. It can last for a couple of minutes. You may have sweating, palpitations, so the heart's racing, chills, and then anxiety. They can be anywhere from once a day to once per hour. They're very common at night, so they very commonly will interfere with sleep, and therefore can affect people's mood, concentration, ability to go to work. Period changes, another common physical symptom. They can change the timing, the length. You can get more bleeding, more frequent, less frequent. Anything kind of happen around the perimenopausal time. You can get headaches, migraines, bloating, weight gain, dizziness, itchy skin, numbness and tingling in different parts of the body, nausea and digestive problems. Psychologically, we know we can get mood swings, memory and concentration issues, depression and anxiety. Depression diagnosis is approximately 2 times more likely in the perimenopausal time than premenopausal. Issues with libido, motivation, tiredness, and insomnia. And lastly, vaginal symptoms. Vaginal dryness and itch is very common, needing to pass urine more frequently, recurrent urinary tract infections, pain when having sex, pain passing urine, and difficulty controlling the bladder. So how do we manage all that? There are a lot of non-pharmacological ways. So exercises, of course, are a really important tool for maintaining that healthy body weight. Remembering that small elevations in core body temperature can trigger a vasomotor event. We know that exercise can help with quality of life, cognitive functioning, mental health, weight maintenance, cardiovascular disease prevention, and of course maintaining bone density. In terms of diet, a healthy diet, so low sugar, low salt, saturated fat, lots of calcium, fibre, reducing coffee, tea, alcohol, stopping smoking, particularly important for bone density as well. Things like mindfulness, yoga, acupuncture might have some evidence behind them. Cognitive behavioural therapy might be helpful. Pelvic floor management, really important and discussed later by our pelvic health physiotherapist. Clothing, so breathable fabrics, and remembering that a lot of activewear is not breathable. And contraception. Until someone is confirmed to be postmenopausal, they still need ongoing contraception. And lastly, workplace management. So things like easy access to temperature control and fans, hopefully having a reasonably open chain of command where you can have some good discussions about what would help. The ability to be flexible and work from home when symptoms are particularly severe or there are some extremes in weather. And menopausal information for both men and women as part of the organisational health and wellness agendas. Then we move into pharmacological but non-hormonal options. We have things like oxybutynin, antidepressants, and gabapentin. They mostly help with the hot flashes, though of course the antidepressants will help with mood and anxiety issues as well. And then our MHT, so menopausal hormone therapy, used to be called HRT, hormone replacement therapy. Effectively, what happens is there is a combination of estrogen, which replaces the falling estrogen, and then that is supported by progesterone. And usually people are on a combination of the two of them. The only people who are on estrogen only are those without a uterus. So the MHT regime might look cyclical, so they might only take it at certain times of the month, and that can produce withdrawal bleeds, or they can have it continuous, so taking it every day of the month, and that should have no bleeding. Bleeding after the menopause is considered something that we need to look into and investigate. Estrogen can be in the form of patches, gels, or tablets, and progesterone is in the form of tablets or a Mirena intrauterine device. Note that things like bioidentical hormones do not have sufficient evidence behind them and are not used. Progesterone creams, for example, are not readily absorbed and do not give sufficient endometrial protection for someone on estrogen. So what are some pros and cons? For most, the benefits outweigh the risks. We aim to commence MHT within 10 years of the menopause because that's the lowest risk of side effects. So you can see there is a risk of breast cancer with combined therapy, but that is dependent on how long they're using it and if they are aged over 60. The risk is small and it does reduce when it's stopped. The risk of a clot because of the estrogen component, higher risk if people are smokers, if they're obese, if they're immobile. There is a higher risk if someone is on oral rather than a patch or a gel estrogen. And we know that oral almost doubles the woman's baseline risk of a stroke. Of a clot, sorry. Stroke is the next one, and we know that it's a higher risk if someone is on oral estrogen compared to, again, a patch or a gel. And stopping menopausal hormone therapy increases someone's risk of a cardiovascular event and a stroke as well. And we know people on MHT have lower risk of diabetes and colon cancer if they're on a combined regime. Stopping it is a very individual decision in discussion with the prescribing doctor. If someone is under the age of 45 at menopause, so quite young, then we'll suggest that they take it until at least 50, which is the age most commonly people go through menopause. Otherwise, it's essentially up to the individual and the prescriber for when they stop it.